Brian Camise, and this is your lecture on fluid and electrolytes for Nursing 125. This is the only lecture that I'm going to do on this. Okay, my contact information is on the screen, but like you'll see on the next slide, if you have questions about this material, I request that you post it on the discussion board in Canvas. If you've got a question, odds are very high that somebody else has the exact same question. So if I answer it there, everyone is able to see it. I'm not going to do individual answers to emails because, like I said, if you've got the question, probably somebody else has the exact same question. Right. For this lecture, too often people want to know what's important. What do I need to know? Well, it's all important. All of these lectures, it's all important. You'll notice that when we do testing, the majority of our test questions are on application. Very seldom do we ask you for something that's specifically memorization and retention. So you need all of this in order to be able to answer the application questions. If you have a question about something that we cover in here, please write it down and post it on the discussion board. The discussion board should be open by the time this is available to you, and it'll stay open until the Friday before the upcoming exam on the material. I like to do the application of the material in the class. I like to do case studies. I like to do NCLEX style questions. I like to do discussions about situations, because as we learn to think like nurses, it's not just the material, is what we're doing with the material appropriate for the situation. Last semester I had a student who got one of my test questions wrong, and she went right back to the book and gave me exactly where she got her answer, and it was a good answer, but the answer was not appropriate for the patient in question. You had to add more to it, which I'm going to say this repeatedly throughout the semester. If you read one of the questions and you say, yeah, but what if, you're making the question more complex than what it is. Keep it simple. We try to give you everything you need in the STEM. Last but not least, another caution. The values that I'm going to use and hold you responsible for any test questions are coming out of the book. It doesn't come from what you were taught last semester. It doesn't come from what you saw in your clinical setting. It doesn't come from what somebody mentioned to you. It all comes from the book. The reason we have to have a set of values that may not match what you'll see in your clinical setting is because in the clinical setting, those values can differ slightly from lab to lab. All right. This lecture is going to have 3 different sections. The first, we're going to do a fluid volume deficit. The next one, we're going to talk about fluid excess. And the very last thing we're going to talk about are the electrolytes. We want things to be equal. We want the fluid that a patient takes in to be equal to the fluid that the patient puts out. The fluid that we're talking about are found in 2 general areas. There's the extracellular fluid, and that's in the intervascular and interstitial spaces. And then there is the intercellular fluid found in the intracellular spaces. We want to, whenever we're monitoring someone for fluid in and fluid out, we want to monitor all of the fluid that the patient is taking in. Usually that's specifically talking about oral and IV fluids. If somebody is getting in normal saline IV at 75 milliliters an hour and then has for lunch an 8-ounce cup of iced tea, we have to calculate all of that together. Things get a little bit less clear when we start talking about fluid out, because there's the fluid that we can measure, such as urine, such as vomit, such as gastric suctioning. And then there's the things we can't measure, and we have to use a guesstimated amount. If we add up the guesstimated amount, the measurable amount that should be very close to what the patient has taken in. The fluid in should equal the fluid out or be very close to it. I'm going to refer you back to your book. The pages are there to see what insensible losses are and where you would see it come from. If fluid out is greater than fluid in, usually that means the patient is in a fluid volume deficit. There are some times where that's not the case, but usually it's because they were in fluid overload and they finally start getting rid of the excess fluid. But usually when fluid out is greater than fluid in, think fluid volume deficit. Dehydration, it's a term we use quite often to mean fluid volume deficit. But dehydration, as it says here, is fluid loss without electrolyte loss. And let's think just salt and potassium. All right. If we lose fluid that has salt and potassium in it in equal amounts to what's in the body, then that's not dehydration. If we just lose the water, the liquid portion, and we keep all of, again, in this case, specifically sodium and potassium, that is dehydration. And I just point that out because we tend to use the word dehydration inappropriately. If the fluid out is less than the fluid in, then the patient is usually in a fluid volume excess. Now, again, just like there can be where somebody already started in fluid overload and they lose fluid, this could be where we're rehydrating somebody because they were in a fluid volume deficit. Few definitions. You'll hear us talk about third spacing. First spacing, and it's not a term we normally use, but that's when your fluid is where it belongs in the amount it belongs. Second spacing is when you have increased interstitial fluid and the patient starts to show signs of edema. But it's still able to circulate fairly easily, and we can compensate for this with things like TED hose or SCDs. Third spacing is the big one. When somebody starts to third space, fluid shifts from the vascular space to another area where fluid normally does not circulate very well. This becomes a trapped fluid. Even though the fluid is still in the body, it's a volume loss because we can't use that fluid to do the things we normally do. It's not used for oxygen and carbon dioxide transport. It's not used for waste transport. It's not used for nutrition transport. This often occurs in interstitial spaces, again, that do not have a normal amount of perfusion. The tricky thing about somebody with third spacing is it's hard to tell how much fluid is not available to them because there's no change in body weight. A liter of fluid is a kilogram. It weighs a kilogram. That's roughly 2.2 pounds. Because the fluid is still in the body, their weight's not going to change even though they don't have sufficient fluid available to the body for its normal functions. All right, let's take a high-level view of developing a fluid volume deficit. Your body loses fluid for whatever reason, from whatever source. Your body loses fluid and you don't take in enough to replace what you're losing. Over time, the blood becomes more concentrated. Your serum sodium level rises. Also, your BUN level will rise. As the blood becomes more concentrated, remember, water follows solid. So the water is going to move out of the cells into the bloodstream because the serum osmolality of the blood is higher than the osmolality of the interior cells. The cells shrink as more fluid shifts out of them, and the patient can have a level of consciousness change. They can develop seizures leading to coma. Sources of these excessive losses. The most common is from the GI tract. It can be because of vomiting, diarrhea, GI suctioning, or intestinal fistulas. The other places we can lose it a little bit harder to track. Excessive renal loss, diabetes insipidus, heavy sweating. If you got somebody that's working outdoors and isn't taking enough fluid to replace what you would lose in the heat that we have here in our area. Trauma that leads to hemorrhage or just hemorrhage. And finally, chronic abuse of laxatives and enemas. And even though that sounds like that would not be that common, you'd be surprised at what people will do to lose weight. So that's seen more than we would expect. Insufficient intake. Okay, you're losing fluid. Why would you not just drink more fluid? Well, it could be because you don't have access to them. Maybe you're somewhere where you can't get to fluid, again, working out in a field somewhere in the heat, and you don't have enough fluid with you. That happened to me once when I went scuba diving. I'm surrounded by salt water and not a drop to drink, and needless to say, I got a little bit goofy by the end of the day. What if somebody is intubated or has an altered level of consciousness? Then they can't tell you that they're thirsty, or they have something that impairs their ability to swallow fluid. Oral trauma, if you're not able to take things orally, immediately you're going to have problems with fluid. Older people also can have an altered thirst mechanism, and it's not only just older people that might suffer from this, but commonly older people have this problem. Then you could have the failure of regulatory mechanisms and fluid shifts within the body. Again, going back to diabetes insipidus. Burns. Who hasn't burned themselves and then ended up with a huge water-filled blister? You could have fluid that leaks into interstitial spaces, causing edema or third spacing. All right. Elderly are always a special consideration for us. We're seeing a lot more older people, so as nurses we have to be prepared to deal with the problems you will see in the older population. Older adults, again, they have less of a sense of being thirsty, and they don't have the same hormonal response to a lack of fluid. They can have changes in their mental abilities, all the medications that they're on. When you're young, you may take 1 or 2 meds daily, if any at all. As you get older, the number that you take every day starts to build, and the problems associated with the medications become more likely due to the medications' adverse effects from the cumulative effects of the medications. Again, older people, what if you can't get around? You're in a wheelchair. You're not able to walk. My mother will deliberately not drink a lot of fluid because she's in a wheelchair and she doesn't want to have to keep getting up to go to the bathroom. And that comes under voluntary fluid restriction. They choose not. These are the manifestations of a fluid volume deficit. Altered mental status, dry mucous membranes, tongue furrows, itchy skin, brittle hair, loss of thirst reflex, thirst itself, lethargy. Again, that goes back to that change in mental status. Dry mucous membranes, reduced urine output. Speaking of urine output, what is the minimum urine output that you want to see in a patient? Rule of thumb, you want to see 30 milliliters an hour. Now, there actually is a weight-based calculation, but just a quick rule of thumb, if you've got somebody that's putting out less than 30 milliliters an hour on average, then you have somebody that's having a problem with urine output, and you need to investigate and figure out why. Weight loss. Remember I said that a liter weighs approximately 2.2 pounds. That's one of the reasons that we weigh patients every day, is to see see whether or not there has been some type of shift. Skin turgor, but you can't really use this as much in the elderly because of the loss of subcutaneous fat. Their skin has less turgor to it and is more prone to tinting. You can also see hypotension. Now, I don't know if I cover it later, but If you've got hypotension, your body's going to try to compensate for that and you become tachycardic. When you've got somebody whose blood pressure is, let's say, 90/60 and has a heart rate of 120, chances are this is somebody that is in a fluid volume deficit. The heart is trying to compensate for not as much to pump, and that's the best it can do. Collaboration. Diagnostic tests, BMP, Chem 7, Chemistry 7. We're going to talk a little bit more about that later, but that's an electrolyte panel. BUN and creatinine, also part of the BMP. If the BUN is elevated and the creatinine is elevated, it's a chronic condition. If just the BUN is elevated, shame on me for saying BUN instead of BUN, but if the BUN is elevated and the creatinine is not, it's an acute condition. You can also check the urine specific gravity. Clinical therapies, the safest thing to do is to get people to drink more. The normal route of intake is always best. Secondary, intravenous fluids. When they cannot ingest the fluids or cannot protect their airways, or they're intubated, or they're extremely dehydrated, then we'll start talking about intravenous fluids. ADPI. History is always a part of your assessment. If you haven't got a patient's history, you don't have everything you need to make a complete picture. Here are some of the things you're liable to see. Your assessment, the physical assessment. How much did they weigh? Is that their normal weight? Have they lost weight? Have they put on weight? Vital signs. Are they tachycardic and hypotensive? Are they hypertensive and tachycardic? Peripheral pulses. If you've got somebody that's in a fluid deficit, what do you think their peripheral pulses are going to feel like? Are they going to be strong or are they going to be thready? Capillary refill. How fast do you think the fluid's going to get back to the fingertips after you squeeze if there's not as much fluid in there, if there's not as much pressure pushing the fluid forward? JVD, jugular vein distension. If somebody is in a fluid overload, if they're overloaded with fluid, they're going to have JVD. It'll be distended. If somebody is in a deficit, the jugular vein is going to stay flat. Skin color, temperature, turgor. Mentation. When somebody's sodium's off, always think initially mentation, mental ability. And again, urine output. If you don't have a lot of fluid to waste, your body's going to conserve as much as it can to keep the blood pressure up. Once the blood pressure starts to drop, the body is going to shunt fluid away from the kidney. Okay, diagnosis, the D of ADPI. And these are not all of them, but these are just some suggestions. You could diagnose a patient with deficient volume, ineffective perfusion, risk for injury. Think back to what we just said about the mentation changes. Confusion, activity intolerance. If you're having blood pressure problems, then are you really going to be able to sit up? You end up with orthostatic hypotension as you try to go from a lying position to a standing position. Planning. What are we going to do about it? We want to get their fluid and electrolyte back into balance. How are we going to do this? If we're going to have somebody drink 1,500 milliliters a day, and this is just an example, is that sufficient? Is that what they really need to have? Your book says that the average person is going to take in 2.1 to 2.5 liters of fluid a day. So 1,500 can be part of it, but that's still anywhere from 600 to a liter low for what the normal patient will need in a day. And if we're trying to replenish fluid, then it needs to be more than that. Let's see. We need to make sure they're getting their electrolytes back. If they're going out, again, working in the field in this good old New Orleans heat, they're going to be losing lots of salt from the perspiration. Sports drinks might be a reasonable thing for them to do to get those fluids back in them. Client will return to normal hydration status and not develop hypovolemic shock. How are we going to do this? What are we going to do to get that going? You need to know what they're taking in. You need to know what they're putting out. Sometimes in severe situations, doctors, in particular nephrologists, are going to want to know the in and out over shorter periods of time. We need to weigh clients every day, and you'll often, well, not often, too often you'll see a client whose weight has had a huge change, and it's because the difference of the scales that they were weighed on. When somebody comes into the hospital where I work, they're weighed in the ER, and there's one weight there. As they're admitted, if they come to critical care, our bed is zeroed out, has the same amount of equipment on it, the same amount of linen on it, and the patient is wearing nothing but the hospital gown. We take a new weight, and that is their base weight. And a lot of times it's significantly different from the weight that they got on the patient in the ER. So if we're trying to report the weight to the doctor, we need to make sure that we're consistent with wherever the patient is, and not talking bad about anybody, but if you have a patient that has a massive change in weight, and let's put that at 5 pounds from a 24 to 48 hour period, you need to investigate what happened. Let's see, you'll also do vital signs. Sometimes you'll have doctors that are going to want you to do a central venous pressure. You'll need a central line to do that. In the hospital, we do vital signs generally every 4 hours. In critical care, they're done every hour. And we administer the fluids that the doctor orders. We monitor the intake because we have to know what did they take in. That includes the oral intake. Too frequently, we'll see where a patient has taken in a bunch of fluid and had no output, or has had a bunch of output and there's no intake, and it's because somebody is not charting what the patient is taking. Can we make an accurate diagnosis of what's going on with this patient if we don't really know what's going on with them? If you administer IV fluids, you're going to want to use an infusion pump because that is the most accurate way to do it. You have drip meters that can be put on the line, and they're not bad in a pinch, but they're just not as accurate. If you're monitoring fluid, you need to be as accurate as you possibly can. You want to monitor your lab values. Remember what I said about BUN. In an acute situation, your BUN is going to go up for a fluid deficit. As we're correcting that, we should see the BUN start to come back down. Sodium level is going to be elevated usually if somebody's in a fluid deficit. It should come back down into normal range. We monitor for changes in LOC and mental status. And this is a huge part about protecting your patient, because if they've had a change in mental status, are they not at risk for injury? We need to move them every 2 hours. There's not a piece of skin on your body that is made to have constant pressure on it. So we have to go back in and move them, or make certain that they have moved if they're able to move on their own, so we don't end up with skin breakdown. As we lose water from the body, remember what we said about it showing in the skin, we lose skin turgor. You start to lose some of the protective cushioning that your skin would provide. Safety precautions, and a huge thing, huge part of what we do as nurses is to teach, 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 teach. Anytime you do a care plan, if you don't have something in there about teaching your patient, you have not done an adequate care plan. Now that we've gotten this far, the very last thing we have to do is to evaluate. Did our efforts show some results? Do we know that we have made an improvement in the patient status? Because we might have to change our plan if we're not seeing any improvement. We can, these are all measures that you would state in a care plan of what you're going to look at to evaluate whether or not it's effective. And remember what I said about urinary output, a minimum of 30 milliliters an hour. minimum. And if we got somebody that's tachycardic because of a of a fluid deficit, as that fluid comes back, the heart should get back to its normal range and the blood pressure should get back to its normal range. Now don't forget that whenever we're talking about normal, it's normal for that patient. No two patients are the same. My mother's heart rate is normally in the 50s and she has great pulses. I suggest at this point take 5. We went through this kind of fast. We're going to do the same thing when we do um, fluid volume excess, and that's exactly what I'm going to do is take 5. All right, my 5 minutes are up, so I'm ready to get started again. I do want to mention to you that because this lecture is recorded, you can change the playback speed. If I'm going too fast for you, you can right click on the image and change your playback to make it slower, or you can even make it faster if you're going back through a second time to make sure you didn't miss anything or something that I mumbled, give you a chance to hear it again. All right, next, volume excess. This, again, very simple, high-level view. Water and sodium are retained in the body. Don't forget that sodium is the most common electrolyte in the body. Its normal range is 135 to 145. Nothing else is as high in the body as sodium. The excess is caused by an overload or impairment of homeostasis, that balancing that should be happening. Too much fluid ends up in the extracellular compartments. This causes hydrostatic pressure and actually forces fluid into the cells. You can have blocked lymphatic drainage, and it's a result of conditions that cause retention of sodium in water, such as kidney damage. All right. Again, this is just a restating of what we said in the previous slide. Excess sodium or fluid is consumed or retained. Remember, fluid follows solids. The fluid moves out of blood vessels into the interstitial space because that's where you have the excess sodium. The extracellular fluid accumulates and edema develops, particularly in the lungs and other tissues. That's one of our biggest concerns about edema and fluid retention is you start to hear crackles in the lungs because fluid is building up in the lungs. Now, this can be caused by heart failure, liver problems, kidney failure, adrenal gland disorders, steroids. Who hasn't known somebody to be put on steroids and they get real plump? Stress can do it. Risk factors. These are related to everything we just went over. Decreased cardiac reserve, decreased cardiac output. Older adults are at greater risk because older adults' organs don't work as well as they did when they were 20 some odd years old. You also have an abnormally increased fluid volume in pregnancy. Heart disease, kidney dysfunction, diabetes, hypertension, IV. Clinical manifestations: weight gain of greater than 5% of body weight or 5 pounds over 1 to 2 days. That can put you in circulatory overload. You'll feel their pulse and they have this bounding pulse. Next, distended neck and peripheral veins. Remember what I said about jugular vein distension? You look at that, you'll look at their neck. I don't remember his name. Doggone it. It's going to come to me after I get done talking about it. But there is a show, The Big Bang Theory. It's in reruns now, but the main character Sheldon on that, when he would talk, I would just stare at his neck veins because they always stood out to me. And whenever you part of being a nurse is when you just see people in normal situations and you see something out of the normal, you start wondering what's going on. All right. Also, increase central venous pressure. And remember, I talked about that earlier. When you're monitoring their fluid level, you'll need a central line in order to do that. Cough, dyspnea, and orthopnea. Again, we talked about fluid building up in the lungs, and you'll hear those crackles. Polyuria, they're trying to get rid of the fluid. You could have ascites, peripheral edema, anasarca. Decreased hematocrit and BUN. Basically, the body's watered down. The solutes in the body have not risen to compensate for the increase in fluid. Cerebral edema, and this is the big thing, altered mental status and anxiety. When somebody is suddenly anxious, explore it. There are so many things that can cause that. But when somebody is anxious, figure out what's going on, particularly if they say, I think I'm dying. Heart failure leading to pulmonary edema. The pressure backs up into the lung space. We stop moving the fluid out of the lungs, and you get that whole crackles in the lungs, difficulty with breathing, and eventually you end up with right-sided heart. Okay, collaboration. We do diagnostic tests, serum electrolytes, serum blood counts, which get your HEB and HCT, hemoglobin, hematocrit, liver functions, renal functions, and in particular, BUN creatinine. BUN's elevated, creatinine's not. It's chronic. BUN's lowered, creatinine's not. It's I said that backwards. BUN is elevated, BUN is elevated, creatinine is not. It is acute. BUN is lowered, creatinine is not. It's still acute. Pharmacologic therapy. Know your diuretics. Again, know your diuretics. Know the names of them. If you've got somebody that has, let's just say a potassium level of 3.4, while not a critical level, it is outside the range. But let's say we're getting ready to give them 80 of Lasix. Are we concerned about that? Lasix is a loop diuretic, and it is going to cause potassium loss. So we might want to call the doctor and say, hey, this morning's lab work came back, patient has a potassium of 3.4. Do you still want to give the loop diuretic, or do you want to change to spironolactone, which is a potassium sparing diuretic? Fluid management. You have to monitor the fluid whenever it's a fluid issue. Dietary management, sodium restricted diet. If they're in a fluid overload, do we want to give them a lot of sodium? Or do we want to try to lower the sodium level so we can bring it back down to normal and the body can lose the fluid? Because remember, fluid follows solids. Okay, fluid restriction guidelines. You need to subtract the required fluids from their daily allowance. Let's say you've got somebody that's only allowed 2 liters a day, but you're going to be giving them an antibiotic that's in 200 milliliters of normal saline. That has to be backed out of the 2 liters, or you have to clarify with the doctor, do you want this backed out, or is this on top of what I'm allowed to give them? You have to divide what the patient can have between the shifts. If somebody's getting 2 liters a day, maybe it's going to be 1,200 on day shift and 800 on night shift, because day shift is going to have the meals and the majority of the medications. Night shift is probably not going to have meals, but they will have the 9 p.m. meds. It helps to know what the client wants to drink. What does your patient want? If you're trying to restrict their fluid, and in doing so, giving them things that they don't want is going to make it more difficult for you and them, because I'm not going to accuse anybody of anything, but clients have a way of all of a sudden coming up with a big old Diet Coke that was not counted or calculated for their daily allowance. You want to place whatever they're getting, you want to put it in small cups. Don't give them a huge cup with 30 milliliters in it, because then that just emphasizes that the psychological effect of that works against you being able to control what they're taking in. Don't forget ice chips. When you give them ice chips, the volume of ice chips is equal to the fluid volume is equal to half of the physical volume. If I fill up a 30 milliliter pill cup with ice chips, I count that as 15 milliliters of fluid. You want to do frequent mouth care. Their mouth is going to be dry, so you're going to want to make sure that you're able to do mouth care, particularly when you've got somebody that's on a ventilator. It helps with their comfort level so much. And sugarless gum. Recommend to them that they chew sugarless. All right, why are we doing this? We want to prevent fluid volume excess in clients at risk, manage the problems resulting from those effects, monitor clients receiving IV fluids for signs of hypervolemia. And now let's get to ADPI. First, there's assessment. Again, history. Always get a history. And there's certain things you're specifically going to look for when you've got somebody you suspect has a fluid volume excess, such as there's somebody who sleeps sitting in the chair. They can't lay down flat. Or you go to check their pulse, their pedal pulses, you roll their socks down, and you can see the indentations in their skin from the socks because they have swelling, they have edema. And then there's, of course, is the physical assessment. Fluid excess, you want to pay particular attention to lung sounds. Are you hearing crackles? Is the patient having lots of coughing? Diagnosis: excessive fluid volume, risk for impaired skin integrity. This is kind of the opposite there of what we had with fluid volume deficit, where there's no cushioning. Here we have to worry about skin being overstretched. Risk for impaired gas exchange, because there's fluid in their lungs. Activity intolerance, because they have impaired gas exchange. Ineffective health maintenance, what got them into this situation. Planning, what are we going to do to make our patients better, never have to come see us again? We want them to regain their fluid balance. We want them to have clear lungs, easy breathing, maintain their skin integrity, able to do ADLs. How are we going to do this? Maintain I&O records, weigh daily, administer oral fluids, record the oral fluids. Oral hygiene every 2 hours. Talk to them about sodium restriction. How can they restrict their sodium? What can they replace the sodium with? Administer medications, monitor responses to the medication, and report changes. Let the doctor know if we've seen something that concerns us. Teach clients about their medicines that they use. If somebody is taking a diuretic, make certain that they know how to take it, what they're supposed to do. Reposition them every 2 hours. Again, this is protecting that skin integrity, reduce skin shearing and friction. Now this one here, I'm sure y'all talked about this in level 1. Do we want to just pull somebody up on their sheet, on the bed sheet, or do we want to have a draw sheet underneath them so we can raise them and move them and not drag the skin across the bed? Provide alternative mattress, cradle, and heel protectors. Float their heels, raise those heels off the bed. That's one of the first places we usually see people have skin issues, is either in the sacrum or the heels. Put them in the fowl position, raise them to make it easier for them to breathe. Monitor your lab results, monitor your oxygen level. Any areas of edema you want to elevate, bring it up. Now we need to look and see, did we do what we needed to do? Are we seeing results from it? We're going to evaluate them by seeing if they're able to maintain a fluid balance. Are they able to participate in activities? Did they maintain their... And I do believe it's time to take a break again. Take another 5, and then we're going to go into electrolytes. All right, electrolytes now. BMP, aka Chemistry 7 or Chem 7. I want to show you something because what I saw in the book is not what I'm used to seeing in the clinical environment, and I just want to mention it to you. Your Chem 7 consists of the positive charge ions, sodium and potassium, the negative charge ions, chloride and bicarb. And bicarb is sometimes shown in the BMP as CO2. If you have a doctor that asks you about a CO2, about a bicarb level, if you look in the Chem 7 and you see CO2 listed, that's your bicarb level. There's also kidney function, which is the BUN and creatinine. Shame on me for continually saying BUN instead of BUN. And also your serum glucose. A fishbone diagram. And the way they listed these, the Chem 7 is not what I'm used to seeing in the clinical environment. So I want to show it to you the way I'm used to seeing it. You have your positive ions, that column on the left, sodium and potassium. Next to that, you have your negative ions, the anions, chloride and bicarb. Next to that is your kidney function, the BUN and creatinine, and finally glucose. This layout, I'm not going to test you on it, on that. You do need to know the numbers for each of these. But I want to put this out there to you, so if you see this drawn in the future, you'll know what that layout is. Positive ions, negative ions, kidney functions, and then blood glucose. All right, let's talk about electrolyte imbalance. The values that you get from your BMP or your CMP, your comprehensive metabolic panel, your basic metabolic panel, are going to tell you a lot about what's going on in the blood. Usually, we gain what we lose. So again, that goes back to that whole homeostasis. What goes out is replaced by what comes in. What comes in is equal to what goes out. When you have an abnormal loss, that's when you get into this uneven balance. And you have to monitor for signs of imbalance, especially in your at-risk clients. And usually we are talking about somebody with multiple comorbidities or elderly. The signs can be very subtle. They can be the same signs that show up for dozens of different things, like nausea and vomiting, for instance. But multi-system effects can compound themselves, and you end up with a client that dies because we don't catch it soon enough. Electrolytes also have they interact. For instance, remember in that BMP that I showed you, at the very end was glucose, and on the left side was potassium. Sometimes when the potassium is very high, what we have to do is shift the potassium into the cells, which is where the potassium is normally found. Sodium is usually outside the cells, potassium is usually inside the cells. So we end up giving the patient insulin, because when the blood glucose shifts into the cells, it takes the potassium with it. But you also have to watch when that happens that you don't drop the blood glucose too low, because your brain does not store glucose. If the blood sugar drops too low, your brain starts to starve. Don't forget that when you have an imbalance, it is seldom just one electrolyte. Sodium. So I mentioned earlier, sodium is the most abundant electrolyte in the extracellular fluid. It's the most abundant in the body. It's used to maintain blood pressure, volume, pH balance, and osmolality. Don't forget what I said earlier. Water follows solids. So wherever that sodium is, your body is going to have fluid shifting. The water is going to go towards the sodium. Aldosterone assists in regulating serum sodium balance. Sodium balance is affected by your food intake. Love me some Popeye's chicken, hate me some Popeye's sodium. The normal range. Your normal ranges, I believe they start being listed on page 372, not just for sodium, but for all of them that are listed. Everything we're going to talk about here, you'll see in the range of page 3. Sodium imbalance, you end up with hypernatremia. When you have hypernatremia, think big and bloated because fluid follows solids, so you're hanging on to fluid. This is a result of excess sodium being eaten or retained or a decrease in water intake. Fluid moves out of blood vessels into the interstitial space. You end up with edema. If edema develops in the lungs, that's when we have to start worrying about oxygen exchange. So something could be very simple when you have it, I don't know, you got fat ankles, you got fluid that builds up in the ankles is completely different when you have fluid that starts to build up into the lungs. It's a different problem. Hyponatremia, when you don't have enough salt. You lose it, you take in too much water, or you're not eating sodium. Your fluid moves from the extracellular space to intracellular space because fluid follows solids. If the osmolality is higher inside the cell than outside the cell, fluid is going to go inside the cell. This can cause cerebral edema and hypovolemia. Hypovolemia, think high heart rate, low blood. Now, things that you'll see when you've got somebody in each of these conditions, they're listed right here. I'm not going to go through it because all I'll be doing is reading it to you. It's potassium. Potassium is the most abundant intracellular electrolyte. It's found inside the cells. So it maintains the osmolality inside the cells. Think of muscle movement, think of electrical impulses when you think of potassium, and also think of heart rhythm. It's also used like sodium to regulate your acid-base balance, and this is the range as potassium imbalance. When it's high, when potassium is high, think tight and cramped. You don't lose potassium. If your potassium intake increases, let's say you're using a salt substitute. Well, usually salt substitutes are made with potassium. So you can end up with an inadvertent increased intake, or you've got somebody that is on a potassium sparing diuretic to take fluid off. They start losing the fluid, but the kidneys are not excreting potassium. The body's hanging on to it. This can cause an elevated level. Or you could have potassium shifting out of the cells into the extracellular fluid, from intracellular to extracellular. When that happens, extracellular potassium level rises. The patient develops neuromuscular and cardiac signs and symptoms. Look for those heart irregularities. Just like they could end up with leg cramps, they could end up with heart cramps. Heart is starting to not beat correctly. This is managed with administration of calcium gluconate. Remember I talked about doing that shift back into the cells. Calcium gluconate, insulin, and if you're going to give that, you also need to give glucose to make sure you don't drop the blood sugar too low. You can also give them K-exolate. K-exolate moves potassium into the intestines. Hypokalemia, just like with hyperkalemia, thought tight and cramp, with hypokalemia, think loosey-goosey. Potassium intake decreases or their loss increases. Let's say you've got somebody on a diuretic like Lasix. Lasix is not potassium sparing. If you give them too much Lasix without monitoring the potassium, you can cause them to be at a critically low level. Potassium, or you could have potassium shift from extracellular fluid to intracellular fluid. If you've got somebody that's taking insulin for diabetes, when the blood glucose shifts from the bloodstream into the cells, it's going to take the potassium with it. You can see your intracellular potassium level rise, and when that happens, electrical impulses are not transmitted properly. Things don't move the way they're supposed to. It's more of a relaxed effect. Hyperkalemia, tight and cramped, muscles don't want to let go. Hypokalemia, it's harder to get the muscles to contract. You end up with muscular, GI, and cardiac dysfunction. This is managed with replacement of potassium. You never, ever bolus potassium. You always monitor their cardiac rhythm when you are giving potassium supplements over IV. All right, chloride imbalance. This is most prevalent in the extracellular fluid. Think sodium chloride, you find them together. With sodium, maintains electricity of the body in a neutral state, and its function is very similar to sodium. It's also used to form hydrochloric acid in the stomach, so if your chloride is too low, you're going to have problems with digestion. Plays a role in the acid-base balance. And with hyperchloremia, nausea and vomiting, swollen and dry tongue, confusion. You can manage this with diuretics, IV fluids, treatment of underlying causes, or dialysis as a last resort. When the chloride level is too low, diarrhea, vomiting, and fever. You can manage this with increased salt in diet. Think salt, sodium chloride. You can add chloride to IV fluids, but you have to treat the underlying cause, what put them in. Calcium imbalance. Calcium is used for neuromuscular transmissions, just like potassium. It helps control muscle contraction and blood clotting. When your calcium level is low, you're going to have bleeding problems. It's used for bone and teeth formation, and it's also used for cellular membrane functioning. Whenever you're trying to raise somebody's calcium level, you're going to need to give them vitamin D. Vitamin D controls the level in the bloodstream, also calcitonin and parathyroid hormone. Hypercalcemia, too much calcium. Constipation, it says bond, I apologize, it's bone pain secondary to calcium loss. You can end up with kidney stones, decreased deep tendon reflexes, and muscle weakness. If the problem is secondary to an elevated parathyroid hormone, you can do a partial parathyroidectomy. If you're given thiazide diuretics, you can switch them to a different type of diuretic. You can do vitamin mineral supplements, and you can put them on a low calcium diet. Hypocalcemia, you end up with diarrhea, tingling around the mouth. Fractures. You don't have enough calcium. Calcium starts coming out of the bones are weakened, and blood clotting becomes an issue, so they're prone to bruising and bleeding, and you can have arrhythmias. It shows up in your heart. Severe symptoms managed with IV replacement of calcium at a moderate rate. If you're doing IV replacement of calcium, again, you want them on a... Now, hypocalcemia, be familiar with these. Trousseau's sign. One of the problems with testing for Trousseau's sign is you're going to inflate that sphygmomanometer, you're going to inflate the blood pressure cuff above their systolic pressure for 3 minutes. Have you ever done that to yourself? Before you do this to a patient, do it to yourself. See what your arm feels like after you inflate that blood pressure cuff above your systolic pressure and leave it there for 3 minutes. But what you can end up seeing is it looks like prolonged spasm of the hand and the wrist. Chvostek sign is really kind of cool. About 2 centimeters in front of the earlobe and below the zygomatic arch. If you tap there, you'll see that side of the face tense up. They almost look like they're winking at you. And that one is an easy check. That one's easy to do. All right, back to ADPI. Assessment. What are we looking at? Review of lab data, ECG, urinalysis, hemoglobin, hematocrit, ABGs, and then your subjective data. Are you thirsty? Are you urinating a lot? Have you been eating? Have you been nauseated? Are you in pain? Do you have cramps? That's the subjective data. The difference between subjective data and objective data is subjective is what they tell you. Objective is what a professional observes. Vital signs, mental status, DTR, deep tendon reflexes, diarrhea, vomiting, heart and lung sounds, and All right, what diagnoses are we going to come up with? Fluid volume deficit, risk for electrolyte imbalances, and decreased cardiac planning. What do we want to do? Client will maintain electrolyte levels within normal limits, be free of symptoms of electrolyte or acid-base imbalance, and maintain regular heart rhythm and out. Implementation. How are we going to get there? Monitor sodium, potassium chloride, and magnesium levels daily. That's a Chem 7 plus magnesium. More often if levels significantly elevated or decreased. Monitor intake and output as indicated by your policy where you work. Observe for signs and symptoms of dehydration. Observe for signs and symptoms of fluid and electrolyte excess or deficiency. Evaluate. How do we know if what we're doing is working for us? We get back to the correct levels. They maintain appropriate weight for their age and height, and they maintain equality of intake and output as evidenced by direct measurement or via journals. Well, the journal entries are going to come from direct measurement that somebody has to do. Okay, we went through this fairly fast. If you have any questions, post them to the discussion board on Canvas. Rules for posting are on the bulletin board. I said here that it's going to open Friday before the first lecture. I'm actually going to open it as soon as I post this lecture. If you have questions and you're not comfortable posting them on the discussion board, you can send me an email. I will transfer your question to the discussion board and talk about it there. I do want to warn you that my answer to you, as often as not, will be a question because I want you to think about what you're asking. Alrighty, folks. Goodbye. Good luck.